Hi, I'm Bronte.
Hi, I'm Miranda.
I'm Charlotte.
Hi, I'm Hannah.
And this is our NUR2106 presentation on coronary artery disease.
Here we have the 10 National Safety and Quality Health Service, or NSQHS standards. We have identified and incorporated the relevant standards throughout our presentation. The standard image can be found on the right-hand side of the slide. Please refer back to the slide for more information about the standard.
Mr. John Small is a 57-year-old interstate truck driver. He suffers from obesity at a weight of 130 kilograms and is also a pack-a-day smoker. He has a family history of diabetes and was diagnosed with type 2 diabetes mellitus early last year. Mr. Small also has a history of hypertension and hypercholesteremia. Mr. Small has presented with significant symptoms associated with coronary artery disease, which include chest pain, radiating burning pain located below the sternum, onset after increased physical activity, is a 7 out of 10 and has significantly subsided, now 2 out of 10. He also has heart palpitations at 110, excessive diaphoresis, dyspnea, hypertension, and patient is highly anxious and agitated.
Atherosclerosis is not a singular disease, but it is a pathological process that can affect vasculature and cause ischemic syndromes. The formation of atherosclerosis begins when arterial endothelial cells become damaged, which triggers a localized inflammatory response, vasoconstriction, clotting, and the release of inflammatory mediators. This inflammatory response causes adhesion molecules to bind monocytes and T cells to the damaged area, and triggers them to release cytokines such as interferons and interleukins and other enzymes that can cause further damage to the artery wall. This inflammatory process triggers the generation of oxygen-free radicals that combine with low-density lipoproteins. The macrophages that have flooded the damaged area engulf debris and the oxidized LDLs, which transforms them into lipid cells known as foam cells. These foam cells penetrate the intima of the artery and form the fatty streak lesions that are characteristic of atherosclerosis. These fatty streaks produce more toxic oxygen-free radicals and cause a further immunological and inflammatory response that results in progressive damage to the artery wall. The macrophages also produce growth factors that stimulate smooth muscle cell growth in the region of the arterial injury. This causes the smooth muscle cells from the tunica media to proliferate, produce collagen, and migrate over the fatty streak into the tunica intima and form a fibrous plaque that is encased by a fibrous cap. These deposits are known as atheromas and protrude into the lumen of the artery, causing it to narrow and obstruct blood flow. In John's case, this is exactly what's happened. His coronary arteries have become over 70% occluded due to the atherosclerotic plaque buildup, which has reduced the blood flow to the myocardium of his heart and caused his intermittent ischemic syndromes.
Common risk factors. Risk factors are non-modifiable or modifiable characteristics that make a person more susceptible to developing a disease, in this case CAD. Non-modifiable factors include age, family history, and gender. Males are more likely to develop CAD. Modifiable includes dyslipidemias, tobacco smoking, diabetes, obesity, hypertension, alcohol intake, diet, sedentary lifestyle, psychosocial factors including stress and anxiety. Our patient, Mr. Small, is impacted by a significant amount of both non-modifiable and modifiable risk factors. Clinical manifestations. Coronary artery disease commonly clinically manifests as pain or discomfort in the upper body, including the chest, left shoulder, back, neck, and sometimes jaw. Rapid or irregular heartbeat, dyspnea, which is difficulty breathing, diaphoresis, which is excessive sweating, fatigue, nausea, and dizziness. Mr. Smalls, our patient, is presenting with some, if not all, of these CAD symptoms.
Complications of coronary artery disease can lead to angina, which is chest pain caused by the narrowing of coronary arteries due to the buildup of an atherosclerotic plaque. Angina can be stable or unstable. Stable angina is chest pain that comes on with exertion of the myocardium, as the coronary arteries cannot meet increased metabolic demands. Stable angina can be relieved by rest. This can lead to unstable angina, which is increasing frequency and severity of chest pain and not relieved by rest. Patients who experience chest pain are restricted by the amount of exercise or daily activities they can do. As dyspnea is often associated with chest pain, their level of functioning is further restricted and can develop anxiety. If the atherosclerotic plaque ruptures, a thrombus may form, occluding blood flow in the artery. This is known as acute coronary syndrome. Lack of blood flow can cause damage to the myocardium known as a myocardial infarction. During an MI, the patient may feel referred pain in the arm, neck, or jaw. The amount of damage to the myocardium depends on how quickly the patient receives treatment. Patients who don't receive treatment can have heart failure where the damage of the heart muscle cannot adequately pump enough blood to meet the body's demands. CAD can also lead to arrhythmias, as damage to the heart muscle can interfere with the heart's electrical impulses and therefore the patient's heart rate. Ventricular fibrillation is the most life-threatening arrhythmia, as the ventricles beat rapidly and erratically, so the heart is unable to pump enough blood around the body. If irreversible damage occurs to the myocardium, this may result in decreased cardiac output as the heart cannot maintain blood flow to the body's organs and tissues, and a decrease in blood supply to the heart, which may ultimately result in sudden cardiac death.
Lipid-lowering drugs. Statins are the first choice drug for lipid-lowering agents. John will be prescribed one of the most commonly used HMG coenzyme A inhibitors called atorvastatin. These drugs inhibit HMG coenzyme A reductase, which limits the rate of cholesterol synthesis that will in turn increase the hepatic cholesterol uptake from the blood. This drug will help to decrease John's total concentration of cholesterol, LDLs, and triglycerides, and cause a small increase in HDL concentration. This will result in a decreased accumulation of foam cells that form the fatty streaks that are essential to atherosclerosis progression. By decreasing this process, you're essentially slowing down the progression of the atherosclerotic plaque, which in turn slows down the decrease in lumen size of the affected arteries and prevents significant worsening of John's condition. Indications. The two main indications of statins is in patients with hypercholesterolemia and those at high risk of coronary artery disease, and they should be used as an adjunct to changes in the patient's diet and exercise regime. Contraindications. When taking statins, severe intercurrent illnesses such as infection, trauma, and metabolic disorders increase the risk of myopathy, rhabdomyolysis, and renal failure, so it is recommended that the medication should be withheld for the duration of this illness. Statins should also be used cautiously in those with renal impairment, as this can also increase the risk of myopathy and rhabdomyolysis, and the patient's renal function and their creatinine kinase levels should be monitored regularly. Side effects. Flatulence, abdominal pain, cramps, nausea, vomiting, constipation, headaches, dizziness, blurred vision, insomnia, fatigue, myopathy, rhabdomyolysis, cataract development, increased concentration of liver enzymes, and acute liver failure. Safety considerations and monitoring. You should avoid stopping statins if there are any symptoms of acute coronary syndrome, as stopping this drug has been associated with an increased rate of cardiac events, especially within the first week after medication cessation. Medication compliance is vital for its effectiveness, so this class of drugs should be taken when convenient for the patient. You should also encourage the patient to make the necessary lifestyle changes. Drug-to-drug interactions are erythromycin, cyclosporin, gemfibrozil, niacin, digoxin or warfarin, estrogen, and grapefruit juice.
Nitrates. Nitrates increase the vasodilation of blood vessels that cause a reduction in venous return, which reduces preload cardiac output and decreases the myocardial oxygen demand. The most widely used drug for this class is glyceryl trinitrate, also known as GTN. This is the drug that our patient will be prescribed in order to manage his ischemic stable angina episodes that are a result of his coronary artery disease. This medication will help to ensure that blood flow to the myocardium is maintained and prevent a myocardial infarction, as well as easing his chest pain. Indications include treatment and prophylaxis of acute angina, chronic heart failure, acute heart failure associated with MI and unstable angina. It is also used to produce controlled hypertension during surgery. Contradictions include hypovolemia, hypertrophic obstructive cardiomyopathy, cardiac tamponade, aortic or mitral stenosis, raised intracranial pressure, and anemia if severe. Adverse effects include headache, dizziness, weakness, nausea, vomiting, incontinence, hypertension, reflex tachycardia, angina, flushing, pallor, diaphoresis, and dermatitis. Safety considerations and monitoring. As this medication can cause postural hypertension, as a nurse you must advise the patient to sit when taking this medication and to get up gradually from sitting or lying. It is important to advise them to sit or lie down if they become dizzy. If the patient is using the sublingual tablets, you must also advise them not to swallow it, as this will prevent the tablet from having its therapeutic effects. If the patient experiences severe headaches from the sublingual GTN tablets, they can spit the tablet out, which should stop the headache. Up to 3 tablets can be taken within 5-minute intervals. Should this not clear the anginal pain, they must be advised to seek further medical help as they could be experiencing acute coronary syndrome. Drug-to-drug interactions should not be used with drugs to treat erectile dysfunction, as it can cause extreme hypertension and cardiovascular events, and it can also decrease the therapeutic effects of heparin.
Antiplatelet agents aspirin. The antiplatelet agent that John will be prescribed is aspirin, as it is cheap and readily available. This drug is indicated in John's case due to its ability to prevent blood clots from forming in the arteries and as such reduce the risk of acute coronary syndrome and stroke. Its inhibition of cyclooxygenase is said to prevent the formation of occluding clots in the blood and at the site of plaque rupture. Indications for this are ischemic stroke, stable and unstable angina, coronary stenting, treatment and prophylaxis of acute myocardial infarction. Adverse effects are GI irritation, hemorrhagic stroke, asymptomatic blood loss, increased bleeding, nausea, and heartburn. Contradictions of this are pregnancy and breastfeeding, allergies, 3 or more alcoholic drinks per day, asthma, bleeding or clotting issues, kidney or liver problems, stomach ulcers, heartburn, stomach pain, influenza or chickenpox, drug-to-drug interactions, carbonic anhydrase inhibitors, anticoagulants or NSAIDs, insulin and oral antidiabetics, angiotensin-converting enzyme inhibitors.
Antihypertensives, beta blockers. John will be prescribed this medication in order to control his hypertension and his stable angina. Beta blockers work by blocking noradrenaline and adrenaline from binding to the beta-1 adrenergic receptors in the heart, which causes a decrease in sympathetic stimulation, thereby reducing the heart rate and contractility of the heart, which reduces cardiac output and results in a decreased oxygen demand for the myocardial cells. This decrease in BP and myocardial demand will mean that John's ischemic angina symptoms will decrease in frequency and severity. Indications: hypertension, angina, tachyarrhythmias. Contraindications: cardiogenic and hypovolemic shock, bradycardia, sick sinus syndrome, vasospastic angina, may worsen first-degree AV block, may impair peripheral circulation, may mask signs of acute hypoglycemia, not recommended in severe asthma as can cause bronchospasms. Adverse effects: bradycardia, hypertension, orthostatic hypertension, nausea, diarrhea, bronchospasm, dyspnea, cold extremities, fatigue, dizziness, alteration of glucose and lipid metabolism. Safety considerations and monitoring. Patients should be started on a low dose that is gradually increased, and they should not stop therapy immediately. It should be done through a gradual reduction of the doses. The patient's heart rate, blood pressure should be monitored during treatment for any signs of adverse effects. Metoprolol can be used either in conjunction with a thiazide diuretic or on its own. Care should be taken with this drug as John is a type 2 diabetic, and this drug can alter blood glucose levels without the common symptoms associated with hypo or hyperglycemia. If this becomes an issue for John, then he could alternatively be prescribed an ACE inhibitor in combination with his diuretic, or just a diuretic if it controls his hypertension sufficiently. Drug-to-drug interactions: amiodarone, cimetidine, paroxetine, rofamapicin.
Monitoring symptoms and vital signs. It is recommended to comfortably position the patient. It is ideal to put them in the semi-phallus position as it allows for chest expansion and improves oxygenation. Pain assessment using a scale of 0 to 10 and PQRST. This is recommended before and after administration of GTN. Determination of vital signs and observe for signs of respiratory distress. Assess vital signs as long as the patient is experiencing pain, then decrease frequency. Pulse. Respiratory rate, administer oxygen if respiratory rate increases, use in tandem with medications. Oxygen saturation, Administer oxygen if O2 sats are decreased. Use in tandem with medications, or 4 to 6 litres via a Hudson mask. Temperature. Blood pressure. Look for signs of hypertension due to administration of GTN. Other tests include 12-lead ECG to look for any heart damage and for dysarrhythmias. Coronary angiography to see how blood flows throughout the heart using dye and x-rays. Troponin blood tests to look for heart tissue damage. Full blood exam, urinary output and input to assess whether a patient is retaining sodium and water and to avoid overloading the heart and lungs, or to see if excess urine is outputted due to side effects of GTN. Lipid profile test. Liver function tests to see if transaminase levels have risen due to administration of atorvastatin. Administration of medications. Atorvastatin, which is used to lower lipid levels, aim is to get levels below 100. GTN, which dilates arterial blood vessels and allows easier blood flow to and from the heart, which in turn helps relieve chest pain associated with angina. This is recommended to administer sublingually and then assess patient's pain score. Aspirin, which reduces blood clots and allows for blood flow through a narrowed artery. Metoprolol reduces heart rate and blood pressure and lowers the workload of the heart. This then can assist in relieving angina symptoms. 6. To manage anxiety. Encourage deep breathing exercises, which also assist with oxygen entering the lungs. Encourage a quiet, calm environment and build a therapeutic relationship and rapport.
Pain and anxiety management. Immediate pain relief should be a priority in John's nursing care, as well as prevention and treatment of potential pain. John presented experiencing significant radiating chest pain. He rated it at 7 out of 10. It has since decreased with rest and glycerol trinitrate to a 2 out of 10. Although the pain has decreased, he is still experiencing some discomfort. An oral analgesic such as aspirin should be administered to relieve John's existing pain. He is likely to experience another angina episode in the future, which will once again cause John pain. In order to treat and manage this pain, John has been prescribed glycerol trinitrate, which will cause vasodilation, addressing the cause of the pain, as well as providing almost instant pain relief. John is also highly anxious and agitated, a reasonable and common response to stressful experiences. Some steps can be taken to alleviate the patient's anxiety. Modifying John's environment by removing distractions such as loud noises, clutter, bright lights may help. Speaking to John in a calm tone and simply reassuring him that he is in a safe environment and that his condition and pain is being treated may also help. Teaching and practicing relaxation techniques such as progressive relaxation, deep breathing, muscle relaxation, and mindfulness could benefit by relieving anxiety immediately and long term. If John continues to experience anxiety, further intervention may be required, including education about anxiety and available mental health services, as well as referral to counselling and psychiatric specialists.
Patient education. Patient education is an individualised and structured tool that nurses can use to improve a patient's knowledge and help them to develop skills to change their behaviours. It is believed that approximately 80% of premature cardiovascular events can be prevented by modifying the patient's lifestyle behaviours. The goal of education in treating a patient with CAD is to implement holistic lifestyle changes such as diet, exercise, limitation of alcohol, and smoking cessation. A sedentary lifestyle can be easily modified. The Australian Heart Foundation recommends at least 30 to 45 minutes of moderate intensity exercise or a brisk walk most days of the week, as it helps to control heart disease risk factors such as high blood pressure, hypercholesterolemia, stress, and being overweight. Good aerobic fitness is important for John's overall health. However, the slowing of the progression of his atherosclerosis in the early stages is a positive side effect of this lifestyle change. Diet plays a significant role in the pathophysiology of atherosclerosis, as it is one of the primary sources of fat that leads to the production of LDLs. In previous years, it has been thought that a low-fat diet would be beneficial to those with atherosclerosis. However, more recently, it has been researched that a whole diet approach needs to be taken rather than solely reducing the fat intake. A diet that is widely researched and has been proven to reduce cardiovascular deaths and myocardial infarctions by up to 30% is the Mediterranean diet. The Mediterranean diet focuses on fruits, vegetables, legumes, whole grains, fish, and olive oil, while it limits the consumption of red meats. This diet contains a good balance of proteins and natural sources of fats, while reducing alcohol intake and saturated and processed food intake. Smoking cessation greatly decreases the risk of coronary artery disease and further progression of the atherosclerotic plaque. It is important for John to understand the impact that smoking has on his CAD so that he has the motivation to follow up on any referrals to quit smoking programs that will help him in his smoking cessation journey.
Nurses are able to suggest and organise referrals for patients who need help to achieve their health goals. For John, the use of quit smoking programs, a nutritionist, and an exercise therapist would greatly enhance his recovery and reduce his chance of a myocardial infarction. Quit smoking programs such as Quit Now or Nicorette use trained counsellors to make personalised quit programs and arrange support groups to encourage patients. They allow the patient to take control of their health without losing independence. Quitting smoking is the most important step in reducing the chance of a heart attack. Chemicals in cigarettes such as carbon monoxide and nicotine promote the formation of atherosclerosis. On average, after 1 year without smoking, patients can reduce their risk of a heart attack by half. Patients who are more independent can choose to use apps such as MyQuitBuddy to help them quit smoking. Regular physical activity prevents the development of coronary artery disease. Exercise therapists specialize in patient-centered physical exercise and recovery. Supervised exercise is recommended for patients with CAD as they need exercise that is tailored to their health and abilities. Furthermore, exercise therapy has been shown to relieve stress and patients' overall well-being. John would also need to be referred to a dietitian to help improve his diet and therefore reduce his CAD symptoms and risk of an MI. Dietitians are trained in health, medical conditions, counselling and nutrition to design and implement a variety of diets individualised for a range of patients. Patients with CAD, their partners and family are susceptible to feelings of anxiety and psychological distress. Psychological interventions such as a counsellor or psychiatrist has been shown to drastically reduce both depression and anxiety and therefore improve patients' quality of life. The aim is to assist the patients cope with the adjustment process post-diagnosis and provide support.